Okay. So chapter 4, we're talking about human technology interface. So anytime human uses technology, there's some type of hardware or software that enables and supports the interaction. And we're going to talk about, interfacing and what that means in terms of healthcare. So workarounds. This is when you circumvent troublesome technology. So, for example, when you, when you order a medication, it comes up as this one stock item, and then you erase everything in there, order it the way it's supposed to, and then use it. That is a workaround, right? Instead of fixing the way the order just pops up. They're Band-Aids. They're usually time costly. They put people at risk, and they don't fix the problem. So, something to talk about. I'm going to show you a little video on interfacing, and then I'm going to show you a video on workarounds.
In the latter part of the first decade of this century, we are moving into a new direction relative to the human interface with technology. For years, we've used keyboards with computers. We've used keypads to input information. Now, all human technology interface is going to be touch and voice activated. Over the past 2 years, we've seen that with the iPhone and now other touch screen phones, and now we're moving into touch screen computers. And we see it in new model cars with Bluetooth when we get in the car and we're driving and we say, phone home. So the voice recognition software dials our home, or call the office. This is going to happen across all technology over the next few years. In fact, my grandson, if I have one, and your grandchildren are going to look at you and go, Grandma, Grandpa, what's a keyboard? Or you actually use keyboards? So here we are, we're moving into the touch voice interaction with technology. The next step coming in the next few years is brainwave interface. Now this is a technology that has come out of medical science to help quadriplegics move their wheelchairs with embedded chips in the brain. We are now going to develop that capability over the next 2 or 3 years in a very fundamental, simplistic way, so that actually our brain waves will be telling our technology what to do. Now this may sound somewhat astounding, but there are consumer products that are coming to the marketplace in 2009 and 2010 with this technology. One way to think of it in a historical perspective is that this simplistic brainwave interface technology the next couple of years will be to brainwave interface in 2020 what the video game Pong in the late 70s is to video games today. So, welcome to touch and voice interface, and get ready for brainwave technology interface between now and 2012.
Okay, in this video, I want to talk about what's called the Poisson distribution.
Now I'm going to talk about workarounds, and I'm going to jump around this video, just because it's long, and I'm going to spend my whole lecture time on this.
Why are they bad, and how do we
So
avoid
they're
them?
asking what are
So
workarounds.
let's start with an example. My friend Rick, he's a dentist. Patient walks in. The guy's eating only soft food. He's chewing on his left side, and on his right side, kind of a pinch between his cheek and gum, he's got an aspirin to alleviate pain. And you start thinking about the situation, what's going to happen? One, the soft food, while he's limited to what he's eating, so he's probably going to end up malnourished if he continues with this working around the problem. You can say facetiously, his jaw's going to cramp up because he's chewing on one side and not using his whole head to do his eating. And he's for sure keep putting an aspirin between his cheek and gum, he's going to get some kind of ulceration. Now, what should he do? What he should do is what he finally realized he should do. He should go to my friend Rick. Rick's going to examine him. He's going to diagnose why he's feeling some kind of pain, discomfort, and so forth. He's going to figure out a treatment plan to deal with that, and whatever the treatment plan is appropriate for that dental problem, he's going to apply the treatment, and then he's going to follow up to see if it worked. And if he does that, what's the consequence? The guy's going to end up in a much better state than the one in which he started. So how does this carry over to the work clinicians do and that we do in general. Well, when we go into the workspace, we're often confronted by risk, by hazard, by acts of omission, commission, inconvenience, and so on and so forth. And very often what we do is we adapt a sort of heroic persona and do just about anything to get the job done. And very often we succeed at getting the job done. But by acting in this heroic way of making do somehow and chasing down this resource, this supply, extending ourselves beyond what was expected or otherwise needed, what we do is we preserve the conditions which caused the problem in the first place. And so we make two guarantees. One, we guarantee for sure that the aggravation we had today, we're going to have that aggravation tomorrow and the day after and the day after that. And the other thing which we guarantee is that we've left the risk in the system and that all the factors which cause us daily aggravation may combine in exactly the right combination to cause a catastrophe. And I don't want to dwell too much and take this into a very depressing direction.
All right. So anyway, that's I'm gonna post the rest of that video so you can watch our workarounds, but that's just the crux of it. We're not going to get into fixing workarounds because that comes later on in the chapter. So examples of human technology interfaces. EMR, a defibrillator, right? It talks to us and it walks us through things. Patient-controlled analgesic pump, drug administration system, any number of physiologic monitoring system, electronic thermometers, and telephones and pagers and texting and all that. So telehealth. This is when we use telecommunication and video conferencing software to communicate more effectively and more frequently with patients at home by using the technology to monitor patients' vital signs and supervise the wound care or demonstrate procedure. So, there's grants out there for telehealth for nurses to check people's blood sugars and then instruct them on what to do based on protocol. One of the older telehealth systems that still work to this day is when a patient weighs himself with heart failure, their scale is connected to a computer system, and then the weight is automatically transponded into the computer, and then an alert will ring for pounds gained over X amount that could indicate that they're going over their fluid restriction, their sodium requirement, or that the heart can be failing. So telehealth interfaces. It allows patients to interact with a virtual clinician, and it's actually a computer program that will ask questions, provide social support, and tailor education to identify patients' needs based on the answers to screening questions. These human technology interfaces have been remarkably successful, and sometimes patients prefer them to live clinicians, maybe because they feel more comfortable. And that's just the way technology has led our society. I don't think that's necessarily a bad thing. People just tend to like it. It's faster. And some people might say, no, like, you have to put your hands on the patient, and that is important. But these are kind of intermediaries for other areas. So, interfacing problem. Major causes of up to 87% of all patient monitoring incidents. It's not always that technology is faulty, but it could perform flawlessly, but the interface design may lead humans to make human errors. So here are the 5-level requirements: physical, physiological, team, organization, and political. Those are the human requirements that need to fit. So is it physically easy to use? Is it psychologically easy to use? Can you work as a team to use it? Does it fit your organization's vision? And politically, does it work? And so you look at task analysis, cognitive task analysis, and cognitive work analysis to kind of decide if, this interface unit works for you. So task analysis, break it down on what it's supposed to do step by step. And then based on your cognitive task analysis, is it intuitive to do that? And what is the workflow behind it? And of course, you want to involve the users, use focus group, cognitive walkthroughs to talk about all the different areas that need to be fixed. Heuristic evaluation, formal usability test, and field study. And the FIT model. So this is what fit between individuals, tasks, and technology. Suggests that each of these factors be considered in designing and evaluating human technology interfaces. Doctors and nurses prescribe patient information differently. Doctors emphasize on diagnosis, treatment, and management, where nurses emphasize on the functional issues and where the patient can function in their environment. So in an ideal world, every human technology interface will be designed to enhance users' workflow and be as easy to use as an ATM machine. And I've screwed up the ATM, I can tell you that.